A training course for doctors in microsclerotherapy, the therapy for telangiectasias and reticular veins. Introduction. Venous diseases, such as varicosis of the lower extremities, are among the most common clinical conditions in the general population. Varicosis is a degenerative disease of the superficial venous system, with pathologically enlarged and tortuous veins, so-called varicose veins. We distinguish between 5 types of varicose veins: saphenous varicose veins, tributary varicose veins, perforating varicose veins, reticular varicose veins, and telangiectasias. In this film, we will concentrate on telangiectasias and reticular varicose veins, which are classified as C1 varices according to the CAP classification, and which are seen in approximately 60% of all adults in Germany. Telangiectasias are enlarged intradermal veins with a diameter of up to 1 mm. The reddish or bluish veins often have a fan-like or star-shaped appearance. Reticular varicose veins are located at the transition of the dermis to the subcutis. They often form a branched network and have a diameter of 1 to 3 mm. Both types of varicose veins occur particularly on the lateral thigh and lower leg and in the popliteal cavity. They usually have only slight or no hemodynamic effects. Symptoms such as heavy legs, stabbing pain, and a sensation of tension in the legs can occur. Usually, however, patients consult their doctor because they feel the telangiectasias and reticular varicose veins to be a cosmetic problem. From the point of view of the practice-based physician, sclerotherapy is the most economical and effective way of treating telangiectasias and reticular veins. Diagnosis. Adequate diagnostic testing is necessary prior to every sclerotherapy, as telangiectasias can represent the first visible symptom of chronic venous insufficiency. The diagnostic testing includes taking a medical history, clinical examination, and, ideally, Doppler or duplex sonography. Ultrasound examination can exclude diseases of the deep venous system and detect pathological reflux in the superficial venous system. To examine the great saphenous vein, the course of the vein is followed to the saphenofemoral junction, where a check is made for pathological reflux. Subsequently, the small saphenous vein is examined, particularly at its opening into the popliteal vein in the popliteal cavity. After the diagnosis has been made, a treatment plan is worked out together with the patient. It is important to explain to the patient that the venous remodeling process can take time. That means that it might take several weeks and several sessions to achieve an optimal aesthetic result. In this discussion, the patient is given detailed information about sclerotherapy. Sclerotherapy. According to the guidelines of the German Society of Phlebology, sclerotherapy is the method of choice for the treatment of small varicose veins. Sclerotherapy of telangiectasias and reticular varicose veins is also called microsclerotherapy. Sclerotherapy comprises the methodical elimination of varicose veins by injecting a sclerosing agent into the affected veins. The sclerosing agent damages the endothelium, leading to occlusion of the vein in that area. Over time, a fibrous cord forms through physiological remodeling processes. This fibrous cord is no longer capable of recanalization. Its functional outcome is equivalent to the surgical removal of a varicose vein. Ethoxysclerol contains the sclerosing agent polidocanol with the INN name lorimacrogol 400, which has proved to be safe and efficacious over many years. Usually, telangiectasias and reticular varicose veins are sclerosed while the patient is lying down. The skin area to be treated is disinfected. Most telangiectasias originate in a feeding vein, which forms the telangiectasias in its vicinity. These feeding veins and the confluence points of the telangiectasias should be sclerosed first, so that all the telangiectasias in one area can be treated with one injection. Depending on the diameter of the vein, 0.25, 0.5 or 1% ethoxysclerol is used. When treating telangiectasias, liquid etoxyscleral should be used. Etoxyscleral 0.25% and 0.5% are approved for telangiectasias. Etoxyscleral 1% can additionally be used for the central veins of telangiectasias. Etoxyscleral 1% is usually used for the treatment of reticular varicose veins. For telangiectasias, 0.1 to 0.2 milliliters per injection is administered. For reticular varicose veins, up to 0.3 milliliters. All injections must be given intravenously. Per session, a total dose of 2 mg polidocanol per kilogram body weight should not be exceeded. Several small doses should be injected at various sites. The veins are punctured with a fine cannula mounted on the syringe, and the sclerosing agent is injected. 27 to 30 gauge cannulas are generally used for telangiectasias, and 25 to 27 gauge cannulas for reticular varicose veins. Smooth-moving syringes should be used for injection, as this makes the intravascular injection easier to control. As a rule, 2 and 5 milliliter disposable syringes are used. The puncture should preferably be carried out tangentially to the skin. For the injection, the doctor stretches one hand over the varicose veins, so that the other hand can be used for the injection. The aspirated blood flowing back into the syringe shows that the cannula is in the correct intravenous position. Aspiration is not usually possible for telangiectasias, but it is recommended for reticular varicose veins. Paravenous injection should be avoided. During the injection, localized decoloration of the veins occurs, as the injected sclerosing agent displaces the blood in the veins. In order to prevent side effects, the application of strong pressure should be avoided during the injection. Paravenous injection results in the development of a wheal. In this case, the injection must be stopped immediately, and also if the patient complains of severe pain. With the aid of a vein detector, such as the mobile battery-operated vein light LED, superficial veins are easier to find. The red or orange lights of the LED ring lights allow very clear visualization of telangiectasias and reticular veins, resulting in targeted, faster, and more effective sclerosing. The vein light is particularly useful in showing the feeding veins of telangiectasias, which, without the vein light, are often invisible and hence remain untreated. Untreated feeding veins can result in unsuccessful therapy. For reasons of hygiene, disposable protective covers are recommended for the vein light. To allow better visualization, however, the use of protective covers was deliberately avoided in this film. After the initial decoloration, the treated area usually becomes slightly reddened. This is part of the normal reaction to sclerotherapy. Follow-up treatment. The injection is followed directly by local compression, which can be greatly increased by eccentric compression using pressure pads in the treated area. Compression pads can include a rolled-up ball of cotton wool or a compress, fixed over the treated veins with adhesive film or tape. Subsequently, a compression bandage or a compression stocking is applied. The patient usually wears this compression continuously for 24 hours, that is, also at night. The local compression is then removed. The compression stocking should then be worn for about 8 hours during the day, for at least 2 to 7 days. The compression prevents excessive microthrombus formation and hence also hyperpigmentation. Immediately after sclerotherapy, the patient should walk briskly for 30 minutes to prevent thrombosis. Long periods of sitting, for example long car journeys or flights, should be avoided directly after sclerotherapy. During the first few days, sunbathing, sunbeds, saunas, and hot baths should also be avoided. The patient usually attends a follow-up appointment after 1 to 2 weeks. If small, dark blue to black microthrombi have developed in the treated veins. These are removed by means of puncture incision and expression of the blood clot in order to avoid hyperpigmentation. A second follow-up appointment takes place after about 6 weeks. Several sessions at intervals of 1 to 2 weeks may be necessary to ensure the optimal success of therapy. We have now treated the telangiectasias and the reticular varicose veins according to the guidelines, with several injections, using the lowest effective concentration and the lowest possible volume. We have also explained to the patient that the result may not be aesthetically optimal at first and that she just has to be patient, as it can take a few weeks or even months before the treated telangiectasias and reticular varicose veins disappear completely. Having suffered for months or even years from problems with spider veins, I have to say that I am very, very satisfied with the final result. As I have had some pigmentation problems, not everything looks quite perfect, but in my personal view, the end result represents a great improvement. And I would have it done again if necessary, just to feel better about myself and not to have to hide these problems from view. Of the available treatment methods, I actually preferred this therapy because there were some things about the others I just didn't like. For example, laser, because laser always suggests burns to me. I found the injections only very rarely painful. I could feel a slight burning sensation, but I'd say I hardly felt 70 to 80% of the injections at all. Right here there was this crescent-shaped circle with blue and red spider veins, and now it's all disappeared completely. That was the worst area. My opinion regarding the success of the treatment is that if this developed again, I would undoubtedly choose exactly the same treatment method.